What I'm about to tell you may challenge everything you've believed about heart disease. For decades, nearly half a century, you were taught one simple message: cholesterol is the villain. Lower it, and you'll protect your heart. So you skipped eggs. You followed low-fat diets. You tracked LDL numbers obsessively. Many of you took statins without question. But here's the truth most people were never told. Nearly half of all heart attacks occur in people with completely normal cholesterol levels. Half. At the same time, there are millions of people living with elevated cholesterol who never develop heart disease at all. So cholesterol alone cannot be the real cause. Something else is driving heart attacks. Something far more dangerous. And it's been right in front of us the entire time. I'm Dr. Maria Lee. After more than 20 years in cardiology, I've seen this pattern repeat endlessly. A patient walks in with excellent cholesterol numbers. They're compliant with medication, eating low-fat foods, doing exactly what they were told. Then suddenly, without warning, a massive heart attack. Everyone is shocked. The labs looked good. Cholesterol was controlled. So everyone assumed the heart was safe. But we were focused on the wrong enemy. We were fighting yesterday's battle while the real threat was silently damaging arteries beneath the surface. The true culprit is not cholesterol. It's inflammation. Chronic inflammation inside your blood vessels. Inflammation is what turns cholesterol from a relatively harmless molecule into a dangerous weapon. Without inflammation, cholesterol tends to circulate without causing harm. But when arteries are inflamed, cholesterol penetrates damaged vessel walls, builds unstable plaques, triggers clot formation, and causes heart attacks. This is the part rarely explained. Because if inflammation is the real problem, then cholesterol-lowering drugs alone are not the full solution. By the end of this video, you'll understand why inflammation is more dangerous than cholesterol, how to know if your arteries are inflamed, and, most importantly, what you can do to stop it. This is not speculation. This is modern cardiology that can save your life. Let me tell you about David. David was 65, a retired engineer who paid close attention to his health. Every year, his doctor checked his cholesterol. His numbers were outstanding. Total cholesterol, 160. LDL, 85. Excellent, his doctor said. Your heart is well protected. David believed it. He was doing everything right. Then one morning, while reading the newspaper, he felt crushing chest pain. He couldn't breathe. His wife called emergency services immediately. By the time he reached the hospital, he was in the middle of a massive heart attack. Emergency imaging revealed a 95% blockage in one of his coronary arteries. A stent was placed immediately. His life was saved. But one question haunted everyone. How does someone with an LDL of 85 end up with a nearly completely blocked artery? The answer was in a test that had never been ordered. After the heart attack, we checked his CRP, his inflammation marker. It was 9.2, severely elevated. David's arteries had been inflamed for years. That inflammation allowed cholesterol to lodge into his vessel walls despite perfect cholesterol numbers. Here's the mechanism everyone needs to understand. Cholesterol does not randomly attach to healthy arteries. It needs damage first. Inflammation injures the lining of the blood vessels, making them sticky and vulnerable. Cholesterol particles then seep into these damaged areas. The immune system responds, sending white blood cells to clean up the mess. But in a chronically inflamed environment, this process fails. White blood cells fill with cholesterol, die, and accumulate as foam cells. These foam cells form plaques. And because inflammation continues, those plaques remain unstable, ready to rupture at any moment. This explains why people with normal cholesterol still suffer heart attacks. Their cholesterol wasn't the issue. Their inflamed arteries were. It also explains why some people with high cholesterol live their entire lives without heart disease. Without inflammation, cholesterol doesn't embed itself into artery walls. The key factor is not the cholesterol level. The key is inflammation. Now let me tell you about Margaret, because her story shows the opposite side of this equation. Margaret was 72. Her doctor was alarmed by her cholesterol. Total cholesterol was 240. LDL was 150. "You need a statin immediately," he told her. Margaret hesitated. She had concerns about side effects, muscle pain, memory issues. She came to me for another opinion. I ran deeper tests. Her CRP was zero point 0.8, extremely low. Almost no inflammation. Advanced lipid testing showed mostly large, buoyant LDL particles, not the small, dense, high-risk type. Her coronary calcium score was 0. No plaque. No arterial damage. Her cholesterol was elevated, but it wasn't harming her arteries because inflammation was absent. I told her she didn't need a statin. Her doctor was furious. He accused me of putting her at risk. That was 10 years ago. Margaret is now 82. She's never taken a statin. Her cholesterol remains around 240, and she has no heart disease because her arteries are not inflamed. The research supports this. The Framingham Heart Study showed that after age 70, high cholesterol is not associated with increased mortality. You know what does predict death and cardiovascular events? Inflammatory markers like CRP. Study after study confirms that CRP predicts heart attacks and strokes more accurately than cholesterol. The Jupiter trial proved this clearly. 18,000 people with normal cholesterol but elevated CRP were studied. Those treated with statins had 44% fewer cardiovascular events, not because cholesterol dropped, but because inflammation did. This is the part rarely emphasized. Statins work largely through anti-inflammatory effects. That's why some people benefit tremendously from them even when cholesterol barely changes. And it's why others see dramatic cholesterol reductions yet still suffer heart attacks, because inflammation remains unchecked. Let me tell you about Robert, because his case shows what actually drives inflammation in the first place. Robert was 68. His cholesterol numbers were unremarkable. Total cholesterol 200, LDL 110. Nothing alarming. But his CRP was 7.8, dangerously high. Robert was significantly overweight, carrying excess fat around his abdomen. His diet was heavy in sugar and refined carbohydrates. He rarely exercised. That visceral belly fat wasn't passive. It was actively producing inflammatory chemicals, cytokines, flooding his bloodstream day after day. Every meal sent his blood sugar soaring, igniting yet another wave of inflammation. And because he rarely exercised, his body had no natural way to counteract it. Despite acceptable cholesterol levels, his arteries were quietly deteriorating. So we reset everything from the ground up. Refined carbohydrates and sugar were removed completely. Vegetables and omega-3 rich fats became staples. He began walking every day and added resistance training to his routine. 8 months later, he had lost 38 pounds. When we rechecked his CRP, it had fallen to 1.9. His cholesterol? Almost unchanged, still hovering around 200. But his heart attack risk had dropped dramatically because we put out the fire of inflammation. Now let me tell you about Patricia, because she asked the question nearly everyone asks. If inflammation is the real problem, she said, why are doctors so focused on cholesterol? Patricia was 71 and frustrated. My doctor keeps pushing statins because my LDL is 140, she told me. But I feel great. And my CRP is 1.2, which you said is good. So why does cholesterol seem to be all that matters? Here's the honest answer. Medicine changes slowly. For 50 years, the cholesterol hypothesis dominated everything. Lower cholesterol, prevent heart attacks. It became unquestioned doctrine. Guidelines were built around it. Drug companies invested billions promoting statins. Insurance systems rewarded cholesterol targets. But the science moved on. We now understand that inflammation is the engine driving heart disease. Cholesterol is often just along for the ride. The problem is that many physicians were trained decades ago, before this research became clear. They're practicing based on what they learned 20 or 30 years earlier. And pharmaceutical companies have little incentive to highlight research showing that weight loss, diet, and inflammation control matter more than pills. There's far more money in lifelong prescriptions than in teaching people how to reduce inflammation. Don't get me wrong, statins absolutely have value. They reduce inflammation and stabilize plaques. For people with prior heart attacks or very high risk, they save lives. But prescribing statins solely based on cholesterol numbers, without assessing inflammation, is outdated medicine. It treats a lab value instead of treating the disease. Let me tell you about Thomas, because his story shows what happens when cholesterol and inflammation are addressed intelligently. Thomas was 74. He'd had a heart attack 3 years earlier. On a statin, his total cholesterol was 180 LDL 95. His cardiologist was satisfied, but Thomas was uneasy. Heart disease ran in his family. His father died young from a heart attack. I checked Thomas's CRP. It was 5.1, still elevated, despite good cholesterol control. The statin was lowering cholesterol, but inflammation was still active. So we expanded the plan. Major dietary changes, regular exercise, omega-3 supplementation, curcumin for inflammation control. 3 months later, his CRP dropped to 1.8. Now both cholesterol and inflammation were controlled. His risk of another heart attack fell substantially. This is the key point. It's not cholesterol versus inflammation. For high-risk individuals, you must manage both. But if you're only lowering cholesterol while ignoring inflammation, you're missing the greater danger. And if inflammation is low, you may not need to be as aggressive with cholesterol targets. This is nuanced, personalized, not a one-size-fits-all approach based solely on LDL numbers. Now let me tell you about Helen, because her case answers the most practical question of all. How do I know if my arteries are inflamed? Helen was 69, worried about her heart. Her mother had died of a heart attack at 75. She wanted clarity about her own risk. We checked her cholesterol. Total 210. LDL 125. Her primary doctor immediately recommended a statin, but I ordered additional testing first. Her CRP was 1.1 low. Her coronary calcium score was 0. No calcified plaque at all. Advanced lipid testing showed mostly large LDL particles. Her HDL was high at 68. Triglycerides were low at 85. Excellent ratios across the board. Helen's cholesterol was mildly elevated, but every other marker indicated low cardiovascular risk. No inflammation. No arterial calcification. Favorable particle profile. I told her she didn't need a statin. She needed to continue her healthy lifestyle. Her doctor disagreed, but Helen trusted the comprehensive evaluation. 5 years later, she's 74. Still no statin. Still no heart disease. Still healthy. Here's the testing panel everyone over 60 should consider. First, a standard lipid panel. Total cholesterol, LDL, HDL, triglycerides. This is your baseline. Second, high-sensitivity CRP to assess inflammation. Below 1 is optimal. 1 to 3 is moderate risk. Above 3 signals high risk. Third, a coronary calcium score, a CT scan measuring calcium buildup in the arteries. 0 is ideal. Above 100 is concerning. Above 400 indicates very high risk. Fourth, advanced lipid testing to evaluate particle size and number. Small, dense LDL particles are dangerous. Large, buoyant particles are far less concerning. Together, these tests provide the full picture, not just cholesterol levels, but whether that cholesterol is actually dangerous, whether your arteries are inflamed, whether plaque is forming. This is modern cardiovascular risk assessment, not simply checking LDL and writing a prescription. So here's what you need to do. Step 1. Get comprehensive testing. Don't settle for a basic lipid panel alone. Ask specifically for high-sensitivity CRP. Discuss coronary calcium scoring. Request advanced lipid testing when available. You deserve the full picture, not just a single number. Step 3 is the most important of all. Put inflammation first. This matters far more than obsessing over cholesterol numbers. If you're carrying excess weight, especially around the abdomen, focus on losing it. Visceral belly fat is not passive. It continuously produces inflammatory chemicals that damage your arteries. Change what you eat. Remove refined carbohydrates and added sugars. These foods spike blood sugar and ignite inflammatory responses throughout the body. Increase omega-3 fatty acids from fish. They're among the most powerful natural anti-inflammatory nutrients we have. Eat more vegetables. They contain compounds that actively calm inflammation at the cellular level. Step 4. Move your body consistently. Walk at least 30 minutes every day. Add resistance training when possible. Exercise is one of the strongest anti-inflammatory therapies available. It lowers CRP, improves insulin sensitivity, and reduces visceral fat, all of which directly decrease inflammation. Step 5. Look for hidden sources of inflammation. If you snore or feel tired despite sleeping, get tested for sleep apnea. Untreated sleep apnea creates massive, ongoing inflammation. Have your gums evaluated. Periodontal disease is a major driver of systemic inflammation. These hidden problems can keep CRP elevated even when diet and exercise improve. Step 6. Consider targeted supplements. Omega-3 fish oil, 2 to 3 grams daily. Curcumin combined with black pepper extract for absorption. Both have been shown in studies to significantly lower inflammatory markers, including CRP, when used consistently. Step 7. Use statins thoughtfully. If you've already had a heart attack or have a very high-risk profile, statins can be life-saving. They reduce inflammation and stabilize plaques. But statins should not be prescribed solely based on cholesterol numbers without understanding inflammation. And if you're taking a statin, confirm that it's lowering your CRP, not just your LDL. Step 8. Monitor regularly. Recheck your CRP every 6 months. If your coronary calcium score is elevated, repeat it every few years. Track your progress and make sure your interventions are actually working. Here's the bottom line. Cholesterol has been blamed for decades. It's not completely innocent, but it's not the primary villain. Inflammation is what makes cholesterol dangerous. Inflammation creates unstable plaques. Inflammation causes those plaques to rupture and form blood clots. When you reduce inflammation, you dramatically reduce heart attack risk, regardless of cholesterol levels. David learned this the hard way. His cholesterol was perfect, yet he suffered a massive heart attack because no one checked his inflammation. Margaret learned it the right way: high cholesterol, low inflammation, and more than a decade without heart disease. The difference was not cholesterol. The difference was inflammation. Don't let outdated thinking put your health at risk. Don't accept your cholesterol is fine as reassurance without knowing your inflammation status. And don't allow statins to be pushed based solely on LDL numbers without a complete risk assessment. Demand better. Demand comprehensive testing. Demand modern cardiology. If this video changed how you think about cholesterol and heart disease, share it. Send it to everyone you know who's been told to obsess over cholesterol numbers alone. Subscribe to this channel because my mission is to give you cutting-edge information that most doctors are still catching up to. Thank you for watching. Take care of your health. And I'll see you in the next video, where we continue revealing the truth about cardiovascular health that could save your life.